This video was produced for www.school.com/keto for cancer. Clinical Research Framework Proposal for Ketogenic Metabolic Therapy in Glioblastoma. Part 1. Abstract. Overview of the current standard of care. Introduction of general press pulse concepts, including the glucose ketone index, GKI. Ketogenic metabolic therapy for lowering blood glucose. Abstract. Glioblastoma, GBM, is the most aggressive primary brain tumor in adults, with a universally lethal prognosis despite maximal standard therapies. Here we present a consensus treatment protocol based on the metabolic requirements of glioblastoma cells for the two major fermentable fuels, glucose and glutamine. Glucose is a source of carbon and ATP synthesis for tumor growth through glycolysis, while glutamine provides nitrogen, carbon, and ATP synthesis through glutaminolysis. As no tumor can grow without anabolic substrates or energy, the simultaneous targeting of glycolysis and glutaminolysis is expected to reduce the proliferation of most, if not all, GBM cells. Ketogenic metabolic therapy, KMT, leverages diet drug combinations that inhibit glycolysis, glutaminolysis, and growth signaling, while shifting energy metabolism to therapeutic ketosis. The glucose ketone index, GKI, is a standardized biomarker for assessing biological compliance, ideally via real-time monitoring. Ketogenic metabolic therapy aims to increase substrate competition and normalize the tumor microenvironment through GKI-adjusted ketogenic diets, calorie restriction and fasting, while also targeting glycolytic and glutaminolytic flux using specific metabolic inhibitors. The proposed strategy may be implemented as a synergistic metabolic priming baseline in glioblastoma as well as other tumors. Background. Standard of care for brain cancer management. Glioblastoma, GBM, the most common and aggressive primary brain tumor in adults, has one of the highest mortality rates of all cancers. Despite the advent of multimodality in neuro-oncology and emergence of novel therapies, long-term survival remains poor for most high-grade brain tumors. In fact, median overall survival, MOS, for glioblastoma is only marginally better today than it was in 1926. 14 to 21 months versus 8 to 14 months respectively. More importantly, incremental improvements in median overall survival or progression-free survival, PFS, should not be confused with long-term survival, which remains less than 0.8% at 10 years from diagnosis. None of the current cytotoxic, molecularly targeted, or immune-based therapies have translated into robust improvements in long-term survival at the population level. When deciding on palliative care, oncologists and patients may have a different understanding of therapeutic goals, and patients may not understand that the proposed treatments are unlikely to be curative, leading to inaccurate expectations. If therapeutic success is defined as long-term survival, it becomes clear that no major advancements have been made in glioblastoma therapy despite a century of cancer research. The current standard of care, SOC, involves maximal safe surgical resection, radiotherapy, and temozolomide chemotherapy, with an average median overall survival across clinical trials of 15.6 months, reaching a 5-year relative survival rate of less than 10%. Unfortunately, clinical trials with various therapies, alone or in combination, have not yet achieved a significant extension of survival. Therefore, patients should be informed of the expected benefits and adverse effects of existing therapeutic approaches to assist with informed consent and shared decision-making. Considering the dismal prognosis despite maximal standard of care, novel clinical research frameworks are urgently needed to drive improvements in quality of life and long-term survival. Cancer is a mitochondrial metabolic disease, an emerging therapeutic paradigm. To address these challenges, we propose research guidelines for the management of glioblastoma, based on the understanding of cancer as a mitochondrial metabolic disease. Two major biochemical processes exist to generate energy in eukaryotic animal cells: substrate-level phosphorylation, SLP, also known as fermentation, and mitochondrial oxidative phosphorylation, OXPHOS, via electron transport chain-induced chemiosmosis. Non-tumoral cells are metabolically flexible. In the presence of oxygen, OXPHOS is sufficient to supply most of the energy requirements in a highly efficient and regulated system, relying on fermentation only under certain physiological conditions. Conversely, SLP fermentation can produce energy in the cytosol and in the mitochondria, independent of OXPHOS. Cancer cells, including glioblastoma, are largely dependent on increased fermentation of glucose and glutamine through the glycolysis and glutaminolysis pathways, regardless of the presence of oxygen. In this protocol, we favor a functional definition of SLP fermentation dependency as the comparatively limited capacity of malignant cells to sustain long-term proliferation when forced to use OXPHOS-exclusive metabolism, e.g., deprivation of glucose and glutamine, the two primary fermentation fuels, at the substrate, transport, or utilization level. Insufficient, or dysfunctional, OXPHOS in cancer cells, as compared to normal cells, is hypothesized to arise from the well-documented and universal abnormalities in the number, structure, dynamics, and collective functional efficiency of the mitochondrial population. To our knowledge, there are no models of cancer that retain aggressive and limitless replicative capacity in the simultaneous absence of glycolysis and glutaminolysis, despite substitution with non-fermentable OXPHOS fuels, e.g., ketone bodies, fatty acids, pyruvate, lactate, as recapitulated by essential nutrient constraints in cell culture. Similarly, neither basic nor clinical research to date supports the notion that tumors with certain mutations, e.g., BRAF V600E, can effectively metabolize fatty acids or ketone bodies to maintain constant growth after effective dual targeting of glucose and glutamine, even if they may do so over short experimental endpoints as long as SLP fermentation flux is maintained. The proposed metabolic dependencies are summarized in Figure 1. From a translational perspective, attaining a sufficient level of nutrient stress in vivo will likely require whole-body physiological adaptations, recapitulating fasting metabolism, as well as pharmacological interventions, metabolic inhibitors, reducing the effective ATP, biosynthetic output of the glycolytic and glutaminolytic pathways. Regrettably, standard glioblastoma therapeutics are not designed to take advantage of the metabolic vulnerabilities of cancer cells. Instead, they focus on DNA repair mechanisms. In fact, as an unintended consequence of nonspecific cell damage, radiotherapy has been shown to induce detrimental metabolic changes and inflammation in the tumor microenvironment, impacting the phenotype of recurrence, which should be weighed against the desirable short-term cytotoxic or immune potentiation effects. In a similar fashion, temozolomide may increase systemic inflammation and tumor driver mutations. Both brain-directed radiotherapy and systemic antineoplastic therapy can result in neurological complications, including brain tissue necrosis, brain atrophy, and neurocognitive impairment, which should be prevented if long-term survival is expected. Furthermore, as part of supportive therapy, patients with brain cancer often receive corticosteroids, e.g. dexamethasone, to reduce vasogenic edema. The injudicious use of corticosteroids has been questioned due to correlations with reduced survival via dysregulated glucose metabolism, increased insulin signaling and immune suppression. While conventional chemoradiotherapies in glioblastoma are well-intentioned, not addressing the unique characteristics of cancer metabolism may hinder their long-term effectiveness. Given the emphasis on patient autonomy in contemporary medical ethics, we advocate for well-informed patients to actively participate in their disease management, fostering supportive follow-up care to explore suitable clinical trials and complementary therapies. Therefore, to reach a broader patient population, novel evidence-based treatments must be developed, tested, and accepted into standard clinical guidelines. In pursuit of this goal, accumulating evidence suggests that targeting glycolysis and glutaminolysis, while transitioning the patient's whole body physiology into therapeutic ketosis, could be an effective and translationally viable antineoplastic strategy. Winter and colleagues coined the term ketogenic metabolic therapy, KMT, to describe the systemic metabolic changes induced by very low carbohydrate ketogenic diets, calorie restriction, or fasting. In the current framework, ketogenic metabolic therapy is redefined and expanded as an umbrella term that includes long-term dietary, physical activity, and lifestyle modifications, requiring objective, measurable biological outcomes, combined with pharmacological targeting of glycolysis, glutaminolysis, and the tumor microenvironment. Ketogenic metabolic therapy is increasingly recognized as an emerging therapeutic approach for a broad range of cancers, while also improving quality of life. Very low carbohydrate, moderate protein, high-fat ketogenic diets, KDs, induce a metabolic state of increased glycolytic substrate competition for cancer cells, while also elevating non-fermentable ketone bodies to serve as an alternative energy source in normal cells. In this context, ketogenic diets, calorie restriction, and fasting are anti-angiogenic, anti-inflammatory, and anti-invasive and can facilitate cancer cell death through multiple mechanisms. Additionally, ketone body metabolism will enhance the delta ATP hydrolysis in normal cells, thus awarding normal cells a bioenergetic advantage over tumor cells. A reduction in the rate of fermentation will also lower the acidity in the tumor microenvironment, subsequently reducing inflammation and potentially limiting distant metastasis. Activities associated with cancer cell proliferation, such as biomass synthesis, are also inhibited by restricting the rate of glucose and glutamine fermentation. It is important to mention, however, that dietary changes alone are unlikely to control tumor progression in most patients. While rigorous calorically restricted ketogenic diets and fasting may be effective in targeting glycolysis, insulin, and growth signaling, they do not adequately inhibit glutaminolysis. Consequently, it will be essential to design and test ketogenic metabolic therapy protocols with drugs that also inhibit glutaminolysis at the substrate, enzyme, or transport level. Current perspectives on leveraging cancer metabolism are mixed and often contradictory, although most agree on the need for combinatorial approaches. We propose that the best possibility of effective metabolic therapies will involve the simultaneous targeting of glucose and glutamine, specifically SLP flux, after whole-body adaptation to therapeutic ketosis, leading to a normalization of the tumor microenvironment and enhancement of OX-PHOS function and adaptive capacity in normal cells. It should be noted that most early clinical trials explored additivity with standard of care of either dietary modification alone, e.g. ketogenic diets, caloric restriction, amino acid depletion, fasting mimicking protocols, or single-pathway metabolic inhibition, e.g. systemic glucose or insulin regulation via metformin or SGLT2 inhibitors, glycolysis inhibitors such as 2-deoxy-D-glucose, glutaminolysis inhibitors such as CB839, or DON prodrugs. In preclinical models, ketogenic diets in monotherapy induce predominantly favorable survival prolonging effects. Experimental factors such as failure to consistently reduce glycemia or insulin, despite increases in ketonemia, diet initiation, before or after tumor implantation, composition, ketogenic ratio, and palatability, as well as ad libitum or restricted feeding, could account for diverging results even when using identical tumor models. For high-grade glioma therapy, a cumulative total of 187 patients have been treated in more than 13 clinical studies thus far, demonstrating feasibility, safety, and tolerability, as well as improvements in quality of life and self-management. Additionally, more than 60 ongoing clinical trials are testing ketogenic diets in combination with standard, immune-based, and other targeted approaches, such as PI3K inhibitors, in glioblastoma and other solid malignancies. Unfortunately, there are no established therapeutic targets for clinical implementation beyond achieving a minimal state of ketosis, usually at a very modest level, meaning more than 0.3 millimolar capillary beta-hydroxybutyrate, and, if possible, sporadic but not sustained improvements in glycemia or insulin signaling. These have not been considered primary endpoints in any published studies so far. We have limited our proposal to mechanisms related to ATP synthesis, with the intention of establishing a clear therapeutic prioritization, SLP fermentation greater than OXPHOS. The goal of this framework is to formalize and build upon previous studies by constructing rational combinatory diet-drug approaches. We aim to minimize off-target effects by following the Press Pulse therapeutic principle, where drugs with a narrow therapeutic index, such as cytotoxic agents or metabolic inhibitors, are carefully dose-escalated and applied intermittently, on a metabolic priming dietary, ketogenic metabolic therapy baseline. Purpose and rationale. Building upon this knowledge, we offer a framework for future research on ketogenic metabolic therapy with additional pharmacological targeting of glycolysis and glutaminolysis, as a minimally toxic therapeutic strategy for glioblastoma management. The resulting shift to a fat-derived ketone body metabolism allows for the relative reduction of glucose and glutamine-driven fermentation, while maintaining normal cell function by upregulating oxidative metabolism and increasing competitive evolutionary pressure. The proposed drugs and strategies are intended to further restrict biosynthetic and bioenergetic pathways in tumor tissues. We have constructed this proposal by synthesizing the expert opinion of researchers and clinicians involved in previous preclinical and translational ketogenic metabolic therapy research. Importantly, while this approach was developed primarily for glioblastoma, the mechanistic basis should be applicable to all malignant cancers exhibiting SLP fermentation dependency on glucose and glutamine, as defined above. In this case, glioblastoma was selected due to poor standard of care outcomes and ethical considerations, as well as the potential benefit of therapeutic ketosis to seizure management and intracranial edema, rather than intrinsic bioenergetic characteristics. In the proposed framework, ketogenic metabolic therapy is positioned as an evolutionarily advantageous prerequisite metabolic priming baseline, upon which other cytotoxic therapies are introduced to assess potential synergy, additivity or antagonism, rationalizing research priorities. A growing body of evidence suggests that well-formulated ketogenic diets can slow tumor progression, but most published reports to date have lacked a robust, modifiable protocol for clinical implementation and data collection. There is a lack of consensus for optimal ketogenic diet therapy in cancer, leading to a heterogeneity of methodological approaches and lapses in effective monitoring. Poor standardization has led to difficulties with interstudy comparability, as not all protocols described as ketogenic will offer therapeutic benefits in cancer-specific settings. A general isocaloric, eucaloric, ad libitum ketogenic diet is not synonymous with dietary ketogenic metabolic therapy. The application of ketogenic diets in cancer should be nuanced and must fulfill a set of measurable biological criteria, with each patient exhibiting an individualized response over time. It is therefore essential to record data systematically, ideally, in real time, correlating cumulative physiological changes with anti-tumor effects. As such, the glucose ketone index, GKI, was developed as a unifying biomarker for assessing biological compliance and outcomes in brain cancer. Ketone body metabolism in cancer. Why therapeutic ketosis? Russell Wilder at the Mayo Clinic formally developed the ketogenic diet as a treatment for pediatric epilepsy in the 1920s. Although various forms of very low carbohydrate diets and fasting have been used empirically for seizure control, diabetes, obesity, and other diseases since antiquity. The prescription of ketogenic diets for epilepsy declined with the advent of new anticonvulsants, but continues to be a cornerstone in the treatment of drug-resistant epilepsy as well as inborn errors of carbohydrate metabolism. Recently, ketogenic diets experienced a major resurgence in clinical applications, particularly for insulin resistance, obesity, and neuroprogressive disorders, while ketogenically compensated glucose modulation as a cancer therapy has been described more than 80 years ago in a case series by Brunings. Achieving stable therapeutic ketosis requires adjustments to the macronutrient composition of the diet. The KD is defined as a dietary pattern that is very low in carbohydrates, typically less than 20 grams per day, which depletes liver glycogen and initiates ketogenesis. Adequate in high-quality protein. Sufficient for muscle maintenance, without excessive contribution to endogenous glucose production, and variable in fat. Depending on whether it is intended to be hypocaloric, loss of adipose tissue, eucaloric, weight maintenance, or hypercaloric, recovery of adipose tissue. Restricted consumption of carbohydrates elicits a physiological metabolic adaptation favoring fat-derived fuels over glucose, resulting in the endogenous production of water-soluble metabolites collectively known as ketone bodies: acetoacetate, beta-hydroxybutyrate, and acetone. Acetoacetate and beta-hydroxybutyrate are synthesized predominantly in the liver and exported into the bloodstream, serving as a glucose substitute for energy and biosynthesis in mitochondrially healthy cells. After ketogenic adaptation, ketone bodies can supply more than 50% of the energy requirements of the human body, and over 70% of the brain's energy needs. From an endocrine perspective, dietary carbohydrate restriction reduces plasma glucose excursions, bolus insulin spikes, and basal insulin levels, thus removing insulin's suppression of key enzymes controlling ketogenesis. Moreover, glucagon secretion decreases over time, further reducing basal hepatic glucose output, glycogenolysis and gluconeogenesis, glucose availability, and basal insulin. Standardizing ketogenic diets for biological efficacy. Different versions of the ketogenic diet have been described in both scientific and lay texts, often including conflicting advice, especially for cancer management. This has led to widespread confusion in the public sphere and obstacles for clinical implementation. It is important to remember that efforts to improve diet adherence, which are vital for patient accrual, are still bound by the GKI or other objective metrics of metabolic and tumor responses. The GKI is the ratio of glucose to beta-hydroxybutyrate, the two metabolites of interest in dietary ketogenic metabolic therapy. Glucose and ketones are assessed by capillary blood sampling using specialized handheld glucometers, or extrapolated from interstitial fluid measurements using real-time wearable monitors. Steady-state GKI levels are used to estimate the degree of therapeutic ketosis and other biological processes, such as insulin signaling, growth-promoting pathways, and systemic inflammation, which are not readily accessible for repeated or real-time sampling, and are generally correlated with persistent decreases in glycemia and increases in ketonemia, resulting in a decreased GKI. The baseline dietary strategy is to follow a macronutrient distribution that facilitates ketogenic adaptation, preserves lean body mass, LBM, and maintains an adequate micronutrient balance, while keeping sustained daily GKI values below 2, ideally near 1 or below. Figure 2. Continuous uninterrupted maintenance of therapeutic GKI ranges may be preferable to occasional, short-term, or cyclical strategies. It is important to note that dietary ketogenic metabolic therapy is defined by a gradual, sustained, whole-body metabolic and endocrine adaptation in fuel partitioning. Absolute blood glucose levels should be consistently below 90 mg per deciliter or 5 millimolar. This is an arbitrary, statistically derived cutoff that has been associated with improved survival, but does not define a known biological constraint. Preclinical and clinical evidence suggests that patients should aim for the lowest, physiologically safe and sustainable glucose and insulin levels, where the proxy, indicating effective insulin suppression, is via elevated blood ketone levels throughout the day, especially during the evening preprandial time. A morning fasted reading can be misleading, as healthy populations, and even type 2 diabetics, can present with low levels of nutritional ketosis after the overnight fast. Classic ketogenic diet, ketogenic ratios, macronutrients, diet adherence. The classic ketogenic diet developed by Wilder is still prescribed in the epilepsy field. In adults, The patient's energy needs are initially calculated using standard formulas in a 3:1 or even a 4:1 ratio of fat grams to combined carbohydrate plus protein grams. The main benefit of this approach is that both carbohydrate and protein are kept very low, together, less than 10% of total calories, making it easier to reach higher levels of ketosis. The classic ketogenic diet may be too rigid for broad clinical application and adherence across heterogeneous cancer populations, but it serves as a well-documented reference template from which to extrapolate introductory practical guidance. Recently, macronutrient distributions have been adapted for classic ketogenic diets, as they are more intuitive than diet ratios. The macronutrient distribution, percent energy, of the classic ketogenic diet is commonly defined as 88 to 90% fat, 6 to 8% protein, and 4% carbohydrate. It should be noted that the daily energy intake will determine the absolute quantity of macronutrients in grams, making flexible distributions less suitable for higher caloric expenditures. For example, a ketogenic diet consisting of 10% carbohydrate for a total caloric intake of 2,500 calories per day equals to approximately 60 grams per day, which may be incompatible with therapeutic ketosis for most patients. At the physiological level, reaching sufficient liver ketogenesis typically involves a carbohydrate intake below 20 to 50 grams per day, depending on the metabolic fitness of the individual. Consequently, the maximum threshold of carbohydrate intake that still allows for the desired degree of ketosis and glycemic control will need to be individually titrated, followed by protein for muscle maintenance, and fat for the desired caloric density. An automated calculator based on the Mifflin-St. Jeor equation is provided in additional File 2, GKI tracking spreadsheet. Diet adherence to classic high-ratio ketogenic diets can be perceived as challenging in free-living adults. However, highly motivated patients with an adequate understanding of the scientific rationale have been able to maintain strict compliance over prolonged periods. Patients with cancer may require more protein to preserve lean body mass, especially if the diet is calorically restricted. In this regard, ketogenic diets with adequate protein and micronutrient content, such as Paleolithic ketogenic diets, which induce a lower than baseline stable GKI, could improve feasibility and long-term compliance. Calorically restricted ketogenic diet, KDR, reaching GKI targets while preserving muscle mass. The classic ketogenic diet was originally intended to be eucaloric or unrestricted, ad libitum, to allow for the appropriate maturation of pediatric patients with epilepsy. And while therapeutic benefits have been reported in preclinical cancer models in both unrestricted and calorically restricted amounts, most clinical studies focused on eucaloric feeding to promote weight maintenance. A failure to reduce proliferation could be a consequence of persistently elevated glucose availability, endocrine, or growth-promoting signaling due to energy surplus, despite shifting to a ketogenic state. In contrast, ketogenic diets consumed in calorically restricted amounts, resulting in a gradual, deliberate reduction of fat mass, with preserved muscle mass, could produce better cumulative, steady-state GKI values, in tandem with the underlying metabolic and signaling effects, such as insulin suppression. Calorie restriction, independent of macronutrient composition, increases metabolic pressure on tumor cells by modulating nutrient-sensing pathways. The calorie-restricted ketogenic diet protocol should be personalized in duration, periodicity and degree, while being monitored to ensure mild calorie restriction does not increase the risk of malnutrition. After setting a carbohydrate limit to induce ketogenesis, and calculating protein requirements to preserve muscle mass, the energy density of the diet will be adjusted by total fat intake. It may be necessary to exclude calorie restriction in malnourished or underweight patients, as a rule, BMI less than 18. In practice, patients with lower body fat percentages can follow the calorie-restricted ketogenic diet in a cyclical fashion, introducing a return to previous isocaloric conditions or a slight caloric surplus when weight recovery is required. These intervals should still be GKI adjusted, that is, adhering to ketogenic ratios and aiming for the lowest possible GKI. In all cases, excessive lean body mass loss should be avoided. A classic calorie-restricted ketogenic diet with a high ketogenic ratio is typically too low in protein for long-term muscle maintenance in adults. Emerging evidence suggests that a well-formulated, protein-sufficient ketogenic diet may exert global anti-cachexic effects by decreasing pro-inflammatory cytokines and metabolites, inducing a protein-sparing metabolic shift, with further anti-catabolic effects mediated by ketone bodies. Therefore, protein intake should be modified for sufficiency, monitoring the impact on GKI, glucose variability, and ketogenesis. Adequate protein intake has either neutral or minor effects on ketogenesis and insulin signaling, as well as hepatic, renal gluconeogenesis. Total protein intake can be started at the minimum recommended daily intake of 0.8 grams per kilogram of body weight for a sedentary individual in isocaloric conditions, and then increased progressively based on factors related to protein needs, such as age, physical activity, or health status. It is important to emphasize that dietary amino acids cannot be restricted for clinically relevant glutamine depletion, as glutamine levels remain relatively stable through de novo synthesis regardless of diet composition. Physical activity coupled with a low-carbohydrate diet as well as prolonged fasting are potential non-pharmacological strategies to achieve transient or chronic reduction in plasma glutamine, respectively. Supplementation of medium-chain triglycerides, MCTs, and exogenous ketone bodies. MCTs, particularly C8 caprylic acid, are a type of dietary fat that can be supplemented to potentiate liver ketogenesis. MCTs bypass normal fat digestion and diffuse across the intestinal membrane into the hepatic capillary bed, where they are readily converted into ketones. Mild gastrointestinal side effects may arise during the initial weeks of supplementation, with tolerance improving through gradual dose escalation. Ketogenic diets with supplemental MCTs typically pre-specify a set daily intake, e.g. 2 to 8 tablespoons, or 10 to 30% of total daily calories in the form of MCTs, which is intended to improve ketonemia, but also to lower other sources of fat, simplifying trial design and improving adherence. A possible drawback of a diet enriched in purified MCTs, as opposed to naturally occurring high-fat foods, is that they are comparatively devoid of micronutrients, particularly liposoluble vitamins. For this reason, overall food choices should emphasize micronutrient density, especially if the baseline ketogenic diet is composed exclusively of medical foods that may be missing essential nutrients, or if significant amounts of dietary supplements such as MCTs are needed to achieve specific biological outcomes, e.g. GKI stability or cachexia prevention. Analogously, exogenous ketone bodies, e.g. ketone esters or ketone salts, are a novel dietary formulation that can be taken orally to temporarily enhance circulating beta-hydroxybutyrate levels. Beyond their bioenergetic role, ketone bodies act as pleiotropic signaling molecules with potential anti-neoplastic benefits on their own. It is unclear, however, whether short-term decreases in the GKI value via supplemental MCTs or exogenous ketones, without a global metabolic transition to therapeutic ketosis by chronic ketogenic diets and/or fasting, would retain protective effects against fermentation fuel inhibition in normal cells. Elevated blood glucose and ketone levels are typically not found during the natural physiology of calorie restriction or fasting. In the context of dietary ketogenic metabolic therapy, exogenous ketones can also have a measurable impact on glycemic regulation. Therefore, supplementation of ketone bodies could be considered to further enhance the therapeutic efficacy of a ketogenic diet or a calorie-restricted ketogenic diet, particularly under circumstances of reduced compliance, or to reach the higher levels hypothesized to mitigate cancer cachexia. In conclusion, supplementation of MCTs and exogenous ketones can be viewed as a valuable tool to empower patients to modulate their ketonemia, ketogenesis, and gluconeogenesis, without being an absolute requirement. Boosting ketone levels while following a GKI-adjusted ketogenic diet may be especially useful during the initial adaptation to fasting, lower limits of euglycemia, radiotherapy, hyperbaric medicine, and conventional and adjuvant drug therapies. Flexible protocols and quantifiable criteria of compliance. Beyond the classic ketogenic diet, several dietary regimens to achieve various degrees of ketosis have been described in clinical studies, including the modified Atkins diet, 60 to 65% fat, 25 to 35% protein, 5 to 10% carbohydrate, high-protein ketogenic diets, 60% fat, 35% protein, 5% carbohydrates, Paleolithic ketogenic diets, based on animal fat, meat and offal, with a 2-to-1 fat-to-protein ratio. Then, Mediterranean ketogenic diets, less than 15% carbohydrates, based on green vegetables, olive oil, fish, and meat. General non-otherwise specified ketogenic diets, 70 to 80% fat, 10 to 20% protein, less than 10% carbohydrate, plant-based, low-carbohydrate diets, generally not sufficiently ketogenic, as well as other targeted and cyclical variations, with or without calorie restriction. Intermittent or prolonged water-only fasting can be included regardless of diet composition. The primary differences are in the maximum limit of carbohydrate and protein, the timing of feeding, and intermittent calorie restriction, as well as the underlying food selection to accommodate personal dietary preferences. Nevertheless, diet flexibility should be contingent upon the patient's individual physiological response. Biological, measurable, and quantifiable effects, not subjective biases or beliefs, will ultimately determine the suitability of the chosen foods. If glycemia, ketonemia, and, by extension, the sustained GKI values are not in the pre-specified target zone, the selected diet may not be appropriate for the patient. Any ketogenic diet protocol, whatever the practical food selection may be, should fulfill the following criteria. 1. Allow for a sustained GKI of 2.0 or below, ideally 1.0 or below. This involves the lowest physiologically achievable absolute glucose levels, ideally less than 5 millimolar or 90 milligrams per deciliter, minimal glycemic variability, difference between the highest and lowest glucose level, as well as reduced insulin signaling and the related growth-promoting and energy-sensing pathways, e.g. PI3K, mTOR. Glucose and beta-hydroxybutyrate are expected to fluctuate depending on carbohydrate and calorie restriction, as well as fasting duration, protein intake, drug therapies, hormonal balance, emotional stress, circadian rhythms, and nutritional status, vitamin and mineral sufficiency. Reaching the proposed GKI targets implicitly translates into lowering carbohydrates to less than 20 to 50 grams per day, regardless of ketogenic ratios or macronutrient percentages, unless concurring with a high level of physical activity. Technologies such as continuous glucose monitoring, CGM, and continuous ketone monitoring, CKM, should be leveraged during the learning phase as the patient explores the impact of different foods on GKI variability. It should be noted that CKM sensors are currently available as non-medical devices, while clinical testing of dual glucose ketone monitoring systems is underway. 2. Patients are often faced with uncertainty regarding optimal GKI targets that would be safe and physiologically attainable, depending on their evolving disease status and concomitant therapies. 2 empirical GKI baselines can be determined to serve as idiosyncratic biological reference points. Once completing the initial ketogenic adaptation via dietary modification, a fasting GKI baseline can be measured after at least 72 hours of water fasting, e.g. days 4 to 7 of a 5 to 7 day water fast, which produces GKI values unaffected by dietary inputs. A zero-carbohydrate, Paleolithic ketogenic diet with intermittent fasting, 1 meal per day, can provide a second baseline that is representative of the lowest GKI variability during minimal dietary inputs, fat and protein only, in a compressed feeding window. All subsequent diet adjustments can be compared to these two benchmarks. During study planning and subsequent data analysis, diet flexibility should not compromise GKI targets. Biological compliance outweighs self-reported or perceived dietary compliance. 3. Adequate protein intake to maintain lean body mass without disrupting GKI, starting at 0.8 grams per kilogram of body weight and typically settling between 1.2 and 1.5 grams per kilogram for most individuals. Higher initial targets are justified in certain patient demographics, e.g. older age, pre-existing comorbidities or anticipated negative impacts of the cancer diagnosis, e.g. loss of appetite during active cancer treatment, or limited physical activity due to cancer fatigue. Protein quality should be a focus to ensure adequate amino acid ratios without forcing protein overconsumption. 4. Changes in lean body mass should be monitored on a regular basis. Patients at borderline low weight or with insufficient lean body mass may alternate between calorie-restricted ketogenic diet and GKI-adjusted eukcaloric or surplus intervals to preserve and rebuild muscle tissue. Although the systemic metabolic alterations induced by tumor-derived factors secreted directly by GBM cells are still under study, functional impairment leading to undernutrition and side effects of treatment may contribute to progressive loss of skeletal muscle. Off-label and research phase anti-catabolic agents, anti-inflammatory drugs, and appetite regulators can synergize with exercise and nutrition therapy to prevent muscle wasting. 5. Adequate micronutrient and vitamin intake. It is preferable to obtain all dietary elements from nutrient-dense foods, e.g. eggs, beef, oily fish, offal. If the included foods cannot maintain adequate levels of certain essential nutrients or minerals, specific multivitamin and mineral supplementation is warranted. Monitor for secondary hypocarnitinaemia and supplement if needed. Macronutrient and micronutrient tracking can be simplified using diet tracking software. Lessons learned from clinical research, evaluating ketogenic diets for GBM. Large-scale clinical integration of precision nutrition for cancer management still poses a challenge, with no consensus on best practices. Consequently, patients tend to freely choose their dietary plan. Additional File 3, Table S1, provides relevant examples of realistically achievable glucose and ketone values that have been reported in studies examining ketogenic diets in high-grade brain tumors. Concerns have been raised about the feasibility of reaching and sustaining the hypothetical therapeutic window of ketogenic metabolic therapy, suggesting that dietary-induced hypoglycemia as a treatment for brain tumors may be simplistic. While a high degree of personal motivation, specific domain knowledge, and, typically, the assistance of a ketogenic diet-trained professional is indeed critical for strict diet adherence, more research is needed to establish causal links between quantifiable metabolic changes and therapeutic outcomes, as well as synergistic pharmacological interventions to enhance efficacy. Common pitfalls in clinical research methodology. Motivated, well-informed patients should understand that objective biomarkers of compliance, such as cumulative time in specific GKI ranges, may influence therapeutic outcomes. Therefore, patients should be instructed to pursue the lowest possible GKI. Ultimately, a GKI-adjusted ketogenic diet or a calorie-restricted ketogenic diet should be considered a long-term strategy, rather than a limited intervention. Patient education and data collection. Tools to monitor blood glucose and ketones. Patients should be counseled on how to use finger prick glucose and ketone meters, initially measuring at least twice a day to capture data variability. Researchers can expand this testing schedule, for example, 1 to 2 hours post-meal, when new foods or changes in portion size are introduced. Real-time continuous glucose monitoring is preferred, maybe even adding continuous ketone monitoring, as these methods deliver more robust data collection and biofeedback. Pre-approved food lists, meal templates, sample meal plans, and recipes to streamline macronutrient tracking. Patients and caregivers will be expected to keep food records, adhere to templates, or use diet tracking software, especially during the diet transition phase. A photographic diary may help with logging and data sharing, with the added benefit of time-stamping the feeding schedule. In the future, image-based food recognition algorithms could reduce logging efforts. Compliance may be compromised if disagreements exist between family members or external healthcare providers regarding the suitability of the treatment plan. Reaching consensus is encouraged, with examination of the scientific literature to resolve any questions regarding the rationale and expected outcomes of all proposed therapies, including standard of care. General and disease-specific educational resources to implement long-term ketogenic diet plans are available for both patients and clinicians. Key steps in the treatment timeline. A chronological timeline is crucial for record-keeping and establishing associations between procedures and therapeutic outcomes or side effects. Figure 3 provides an overview of ketogenic metabolic therapy for high-grade glioma, and Table 3 summarizes key steps in the suggested clinical implementation of dietary and pharmacological ketogenic metabolic therapy. The steps in this timeline are based on the Press Pulse therapeutic strategy. GKI-adjusted ketogenic diet, calorie-restricted ketogenic diet and fasting are implemented as a metabolic press to restrict fermentable fuels, reduce inflammation, and normalize the tumor microenvironment, while drugs that simultaneously target glycolysis, glutaminolysis, and other cancer-associated pathways are defined as either press or pulse interventions, depending on pharmacodynamics and safety. Representative diet-drug combinations have been presented in case reports and pilot clinical trials, although most studies thus far emphasized feasibility and additivity with standard of care, rather than integrating dietary and pharmacological ketogenic metabolic therapy as a prerequisite, continuous, biomarker-driven metabolic priming baseline. Even though adjustments to nutrition and over-the-counter supplementation are within the patient's purview, the use of prescription medication involves the cooperation of a physician trained in metabolic oncology. Lack of familiarity, inertia of prescribing habits, and fear of legal vulnerability can be reasons for not pursuing off-label use within standard practice. Outside research, dietary ketogenic metabolic therapy, ketogenic diet, calorie-restricted ketogenic diet and fasting can be implemented freely by the patient, but active drug repurposing or compassionate use, as allowed by local regulations, requires a clear rationale and informed consent. Tumor diagnosis and shared decision-making. It is preferable, if possible, to make the initial tentative diagnosis using non-invasive neuroimaging techniques, CT, MRI or PET, to avoid the risk of exacerbating tumor growth or iatrogenic cell dissemination through inflammatory oncotaxis. Blood panel analysis. Biomarkers of general health, including hemogram, electrolytes, hepatic and renal function, inflammation and vitamin status, should be within or near the normal range before initiating therapeutic measures that carry a risk of adverse effects. Key dietary nutrients to monitor on a carbohydrate-restricted diet include carnitine, thiamine, folate, pantothenic acid, calcium, phosphorus, iron, vitamin D, and trace minerals. Ketogenic diets, partial fasting, fasting mimicking, and/or water-only fasting can improve pre-existing lifestyle-related blood panel abnormalities, particularly hyperinsulinemia, insulin resistance and chronic inflammation. Metabolic stratification. During routine clinical practice, metabolic targeting can be informed by previous molecular and mechanistic characterizations of the tumor subtype. High uptake of glucose and glutamine is considered a common feature of high-grade gliomas, correlating with cell density and aggressiveness, especially in grade 3 and 4 tumors. A fasting period, longer than 12 hours, is advisable prior to the scan to facilitate 18-FDG transport into the tumor, and lower insulin-mediated glucose uptake in the surrounding tissue. A combination of anatomic and/or metabolic imaging at baseline, and then sequentially every 3 to 6 weeks to corroborate pre-specified outcomes, e.g. stable disease, as advised. Surgical debulking. Surgical debulking should be performed promptly after diagnosis, while still prioritizing careful surgical planning to ensure maximal resection. In asymptomatic or slow-growing tumors, active surveillance provides an opportunity to implement dietary ketogenic metabolic therapy as a neuroprotective intervention prior to surgery, which could reduce angiogenesis, inflammation, and edema. Initiate dietary ketogenic metabolic therapy. This next section is the start of Part 2. Part 2 contains starting the ketogenic metabolic therapy, medications for blood glucose control, implementation of DON to inhibit glutamine, other compounds and supplements, figures and tables. This video was produced for www.school.com/keto for cancer.